Welcome to this explainer. Today we're doing some high-yield surgical clinical rounds. Let's just dive right into the cases.
We'll be hitting 4 wards today: the anorectal clinic, the emergency department, the hepatobiliary wing, and the lower GI ward.
All right, first up, Ward 1, the anorectal clinic.
So here's our first case. We've got a 44-year-old trucker presenting with severe, sharp, tearing pain during defecation. It lasts for hours, which obviously leads to him putting off going to the bathroom, worsening his constipation. On visual inspection, you see a linear mucosal tear right along the posterior midline. What's the diagnosis here? Yep, it's an acute anal fissure.
Now here's an absolutely crucial clinical pearl for you. Never ever perform a standard digital rectal exam or a proctoscopy on these awake patients. It is strictly contraindicated. Why? Because the pain and internal sphincter spasm are just too extreme. Also, keep in mind that over 90% of these idiopathic fissures happen exactly along the posterior midline. It's simply due to a lack of structural support and relative ischemia in that specific area.
Moving on to painless bleeding, we have to rely on the internal hemorrhoid management matrix, which is really driven by the degree of prolapse. It's kind of like a step-up approach. Grade I means no prolapse, so you just manage that with high fiber and stool softeners. Grade 2 has spontaneous reduction, making rubber band ligation your first-line treatment. But remember, apply it strictly above the dentate line. Then for grades 3 and 4, where they require manual reduction or are permanently prolapsed, you're going to need a formal surgical excision.
Let's look at the next one. We have a 38-year-old male presenting with this cyclical, painful perianal discharge. He actually has a history of a previously drained abscess. Now, there's a small opening that occasionally discharges pus, gets really painful when it seals up, and then the pain relieves as soon as it breaks open again. So what's the diagnosis? It's a fistula in ano.
You see, a fistula in ano is essentially just the chronic phase of that previous acute abscess. And to surgically map it out, we use Goodsall's rule. It's a classic. Anterior external openings run in a straight line right into the anal canal, but posterior openings, or honestly anything over 3 centimeters away, follow a curved, horseshoe-like path straight to the posterior midline.
Okay, moving on to Ward 2, the emergency department.
Here's our next question. A middle-aged male comes in with severe abdominal distension, obstipation, and bilious vomiting. You get some x-rays and see multiple air fluid levels. His history includes a midline laparotomy about 6 months ago. So what's the most common cause of this mechanical obstruction? It's intraperitoneal adhesions. Whenever there's prior peritoneal trauma, it triggers this fibrin scar tissue cascade that ends up binding the bowel loops together. In fact, this accounts for over 60% of these cases.
Now, check out this classic diagnostic trap. You have a young female with sudden, severe right iliac fossa pain. It could easily be acute appendicitis, right? Or it could be an unruptured right-sided tubal pregnancy. But if you add a missed cycle, hypotension, tachycardia, and acute anemia to the clinical stem, the diagnosis immediately shifts to a ruptured ectopic pregnancy. The golden rule here? Always mandate a beta HCG pregnancy test.
Next case. A 24-year-old female presents with recurrent, dark red rectal bleeding. A colonoscopy shows fresh blood sitting in the cecal vault, coming right from the ileocecal valve. We're highly suspecting a bleeding Meckel's diverticulum harboring ectopic gastric mucosa. So what is the absolute best test to confirm this ectopic tissue?
The answer is a technetium 99M Meckel's scan. The radiotracer gets selectively taken up by those mucosecreting cells. And you got to remember the classic exam pearl here, the rule of twos. It occurs in 2% of the population, within 2 feet of the ileocecal valve, it's 2 inches long, contains 2 types of ectopic tissue, and usually presents before 2 years of age. Oh, and if you happen to find an uninflamed Meckel's incidentally during an appendicectomy, just leave it in situ. Don't mess with it.
Next up, Ward 3, the hepatobiliary wing. So when your imaging shows uniform dilation of both the intra- and extrahepatic biliary trees, you need to look for the obstruction. Typically, a mass in the head of the pancreas is mechanically compressing the distal common bile duct. That upstream back pressure creates what we call the pathognomonic double duct sign on a CT or MRCP. It's basically the simultaneous dilation of both the biliary and the main pancreatic ducts.
Let's look at this next case. A 24-year-old female on long-term oral contraceptives has this well-demarcated hyperechoic liver mass show up on an ultrasound. We suspect it's a cavernous hemangioma. What's the best test to definitively confirm it? You want a contrast-enhanced CT scan.
What we're looking for is its specific vascular profile, early nodular peripheral enhancement that's followed by a progressive centripetal filling.
And here is an absolutely critical pearl. Never biopsy this lesion. A percutaneous core needle biopsy of a suspected hepatic hemangioma is strictly contraindicated. If you pierce those hypervascular venous lakes, you are looking at catastrophic, uncontrollable intra-abdominal hemorrhage. So confirm it with imaging, never with needles.
All right, final stop on our rounds, Ward 4, lower GI surgical cases.
Here's the question. A severely emaciated male presents with chronic lower abdominal pain, night sweats, right iliac fossa fullness, and ascites. If you need to definitively differentiate abdominal tuberculosis from a GI malignancy, what's the mandate? The answer is a diagnostic laparoscopy with a targeted tissue biopsy. That secures your tissue confirmation while totally bypassing the morbidity of an open laparotomy.
Next one. What is the most common late, long-term complication associated with an end colostomy? The correct answer is a peristomal herniation. Basically, over time, the abdominal contents slowly protrude through the fascial defect that was originally created for the stoma, which is usually positioned lateral to the rectus abdominis.
Let's review this case. We have a 40-year-old male with an isolated 2-centimeter liver metastasis found 6 months post-colon cancer resection. There's no extrahepatic disease. So, what's the next step? You proceed with a formal surgical metastasectomy. And the reason this matters so much is that colorectal cancer represents this really unique oncological paradigm. Resecting an isolated liver met actually provides a genuine long-term chance for a cure.
As you can see, the distance from the anal verge completely dictates the surgical choices for rectal adenocarcinoma. If you want to preserve fecal continence with an anterior resection, the tumor's distal edge absolutely must be at least 2 centimeters proximal to the anorectal ring. If the tumor is directly invading the sphincter, that mandates an abdominoperineal resection, meaning complete excision and a permanent end colostomy.
Historically, surgeons insisted on a 5-centimeter distal clearance margin. But today, the oncological data shows us that a 1 to 2 centimeter margin is completely sufficient when it's paired with neoadjuvant radiotherapy. So as the data keeps evolving and pushing our surgical boundaries closer and closer to the anal verge, it really makes you wonder, how close can we actually get to save the sphincter without sacrificing the cure?